Respected physicians and medical students, welcome you all to today's session of ECG. Today's topic is cardiac arrhythmia. আমাদের আজকে বিডি ফিজিশিয়ানস কর্তৃক আয়োজিত ইসিজি সেশনের আজকে ষষ্ঠ পর্ব। যথারীতি আমাদের মাঝে আজকে উপস্থিত আছেন আন্তর্জাতিক খ্যাতিসম্পন্ন ইলেকট্রোফিজিওলজিস্ট ডাক্তার রফিক আহমেদ। ডাক্তার রফিক আহমেদ স্যার কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট মেডিস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট বেলটিমোর ইউএসএ। এবং আজকে আমাদের সাথে চেয়ারপারসন হিসেবে উপস্থিত আছেন প্রফেসর মাহমুদ হাসান স্যার। প্রফেসর মাহমুদ হাসান স্যার এক্স ভাইস চ্যান্সেলর বিএসএমএমইউ এবং এক্স প্রেসিডেন্ট বিএমএ বাংলাদেশ। আমি আজকের সেশনটি শুরু করার জন্য প্রফেসর মাহমুদ হাসান স্যারকে আহ্বান জানাচ্ছি।
ধন্যবাদ ডক্টর এহসানুজ্জামান সাহেব। বিডি ফিজিশিয়ানসের আজকে এই যে ষষ্ঠ সেশন, আশা করি আপনারা অনেক উপকৃত হয়েছেন। ডক্টর রফিক আহমদ সাহেবের পরিচয় তো এহসানুজ্জামান সাহেব দিলেন, আমরাও আগে আলোচনা করেছি। উনি বাংলাদেশ থেকে কোয়ালিফিকেশন নিলেও এখন বর্তমানে যুক্তরাষ্ট্রে একজন অত্যন্ত উচ্চ পর্যায়ের ইলেকট্রোফিজিওলজিস্ট, এবং ইসিজি শেখার জন্য তার চাইতে আর ভালো শিক্ষক আমার মনে হয় না পাওয়া যাবে। তো আপনারা এই আজকে ষষ্ঠ সেশনটা আরো শিখতে পারবেন, এটাই আমি আশা করি। আমি রফিক আহমদ সাহেবকে আহ্বান জানাচ্ছি শুরু করার জন্য। ধন্যবাদ।
Assalamu alaikum. Good morning. So, Ehsan, somebody send this ECG. I want that person.
স্যার উনি স্যার ঢাকা মেডিকেল কলেজের আইসিইউতে কর্তব্যরত ডাক্তার মেহনাজ। আমি স্যার হয়তো জয়েন করবে স্যার, আমি জয়েন করলে আপনাকে বলবো স্যার। এটা উনি পাঠাইছেন স্যার।
This is not his ECG. This is from a book, I think.
মাইট বি স্যার, হয়তো এটা স্যার সে বুঝার জন্য স্যার আপনাকে করছে ডাক্তার মেহনাজ।
No, there is no point of discussing a book ECG because that discussion is in that book. Okay, and sir, it doesn't add much to conversation. So today the plan was that I want volunteers and active participation. We'll go over ECGs. So I'm going to start with the first ECG, and I need one person. So this one.
Dr. Hanif Ahmed.
Please do participate. You don't have to, as I mentioned before, that you don't have to be a master of ECG or give correct answer. I will help, and we'll do it together.
Okay, Dr. Hanif. আপনার যা মনে আসে বলেন।
I'm telling the heart rate. Heart rate is 60 beats per minute.
Dr. Hanif. Dr. Mahmudul Hasan.
Sir,
হ্যাঁ, যে কোনো একজন।
স্যার আমি rate is 60.
Yes.
And
rhythm
is regular, sir.
Yes, but regular and what? Sinus, junctional, ventricular.
Sir, P wave টা আমি ভালো বুঝতে পারছি না স্যার। P wave টা clearly sir, sinus rhythm, sir.
Okay, why do you say sinus rhythm?
Sir, in lead 2, 3 and ABF, seeing the leads 2, 3 and ABF, it seems it's sinus rhythm.
Okay, what seems sinus rhythm? There is a P wave, right?
Yes, sir.
So there is a P wave followed by QRS. Each QRS is preceded by a P wave.
Yes, sir.
And what is the morphology of the P wave? Why is it sinus? Why is it not atrial rhythm? Presence of P wave means the driver is the atrium. It can be atrium or it can be sinus. So we need to identify that. So we look at the P wave axis. if the P wave is upright in lead 3 AVF and lead 1, that's sinus, because that's coming from the right upper corner. So rhythm is sinus. Okay. So, and then what else? What else will you tell me about this ECG?
Sir, QRS
PR interval?
80 milliseconds, sir.
PR interval.
Sorry, sir. PR interval is 200 milliseconds, sir.
Good, perfect. 5 boxes.
Yes, sir. 200
millisecond. QRS duration 80 millisecond.
80 milliseconds. Yes, sir. I said.
Fine. And then QT?
Prolonged.
No. You cannot just make, I want a measurement.
Yes, sir. I'm saying, sir.
How many millisecond QT interval? Sorry, it moved. Okay.
320, sir.
320, a little bit longer than 320, probably 360 milliseconds. So that's not long.
Yes, sir. Sir, I have
That's
a
what you
network
said.
issue, so I cannot see actually properly. So there is some miscalculation.
Okay.
Okay, sir. Thank you, sir.
Okay. Dr. Sabbir, you raised your hand. Dr. Sabbir, please.
He will do the next one. So I will finish this. So
Okay,
QT, so PR interval is normal. QR is zero, QT interval normal. T wave looks normal. Why it is normal? It is facing towards the direction of the QRS complex. So this is normal sinus rhythm and normal ECG. That's the final comment. Okay, so who is the next person? Sabir, Dr. Sabir.
Assalamualaikum, sir.
Sam. So I tell you the rate.
Sir, rate is approximately 75 beats per minute.
78, 75 is fine. I'll take that. Rhythm.
The rhythm is regular.
Regular.
No, who is the other person? Let one person speak. You can speak. Who is the other person? You can do the next one.
Okay, Dr. Sabbir, finish it.
Yes, sir. Rhythm is regular. Rate is
Yes.
75 beats per minute.
Okay.
Inverted P wave in lead 2, 3, and AVF as well.
So where is it coming from?
Inverted P wave.
Yes, but where is the P wave coming from? Which part of the
Probably from junction.
Okay, junction. You can say low part of the atrium. Low atrial rhythm, right?
Sir,
So it is not a sinus rhythm. You are breaking up.
yes, sir. Low atrial rhythm.
Okay, because you see, 2,
Yes,
3
not
AVF is
sinus,
negative.
other than
Negative.
sinus.
So it is moving away from 2, 3 AVF, right? So it is coming from somewhere in the inferior part of the atrium. So it's an atrial rhythm.
Sir, it is not sinus, other than
You call it an atrial rhythm. If it is not sinus, it looks somewhere else. It's an atrial rhythm.
yes, sir.
Okay. So PR interval.
Yes. Atrial rhythm.
No, what is the PR interval? Can you hear me?
Sir, ওর মনে নেটওয়ার্ক ডিস্টার্ব করতেছে। Dr.
Okay.
Noshin, Dr.
Yeah,
Noshin,
Noshin.
please complete it.
Sir, the PR interval 120 millisecond
Yes.
around.
So look at this. If
30
it
to
were
40 milliseconds.
if it were
30 to
junctional
40.
rhythm, the PR will be shorter.
Short.
So it's yes, much shorter than this. So junction, it is an atrial rhythm. PR is 120. QRS duration.
So Qrs duration is about 80 milliseconds.
Okay. And the QT interval.
So QT interval also seems normal. It is about
No, you tell me the number.
yes, sir. 6. So 240 milliseconds.
No, You see here, if you look at lead V2, one big box, and then about 3, so about 320 milliseconds.
Oh, okay.
So it's important to measure. Don't just say it is normal or it is long or short, just measure it. Right? So the QT interval now. How about the ST segment?
So ST segment is also so normal, but the yes,
No,
sir,
but
the
look
P
at
waves.
no,
Okay.
V5, V6, is the ST segment looking normal or is it looking downward a little bit?
So a little bit downward, but I cannot count any boxes
You
that
don't have
they
to, but it looks kind of down.
Yes, sir.
And the T wave is biphasic.
Yes, sir. T waves are
So,
biphasic.
but where is this P? Which part of the atrium do you think is coming from?
Sir, I think this is coming from the left atrium, the P waves.
Why? Why?
Because in V4, V5, V6, the P is inverted.
Okay, perfect. Look at this picture. If the P wave is electricity is moving away from V6, it will be negative in V6. So I have taken those P wave and superimposed on this grid. You see the P is negative in V6. That means it is moving away from it. Only way it can move away from it if it is in the left atrium. This is a very typical ECG. So inverted into 3-way, V5, V6, left atrial rhythm with STT wave changes by. Thank you.
Thank you, sir.
Who will do this one?
Okay, Dr. Hanif, it's your turn.
Heart rate is 44 beats per minute.
Assalamu alaikum, sir. Heart rate is, sir, regular, and there is no P wave in lead 2-3B AVF. Hello?
Okay, there is no P wave at all.
Yes, sir. There is no P wave, but there is a small wave in lead 2 just after QRS complex.
Okay. So where is this rhythm coming from?
It's maybe it's a junctional rhythm.
Good. Junction rhythm rate 44 beats per minute. Anything else you want to tell me about this? QRS duration looks normal.
Sir, QRS durations are 120 milliseconds, and sir.
No. You see, you cannot see the grid. You cannot see the grid, so you cannot measure it. You can just tell me it just looks normal, maybe.
Yes,
but
sir.
there is no grid, so you cannot measure it. So
Yes,
junction rhythm.
Sir, junctional rhythm, QRS durations are normal. ST segments are normal, and there is T wave inversion is lead V1.
But lead V1 T inversion, is it normal or abnormal?
Sir, it is within normal, sir.
Good. So the diagnosis of this is junctional rhythm. Look at the same patient. This is 6 August at 23:12. What's happening here? Can you look at lead 2 rhythm strip?
Yes, sir. Sir, there is P wave, sir, in front of QRS complex, but there is a short pair interval, sir.
So do you think this is conducting?
If we see the whole lead, sir, there is only 2 P wave conducting QRS complex. In others, there is no P wave before QRS complex, sir. So it may not conducting, sir.
Okay. So what happening here, I'll tell you. This P wave happened, probably did not conduct. This is just a junctional beat.
Yes.
This one may or may not have conducted, but then the junction takes over. I'm going to show you another ECG. Same patient, look at it is reverse thing happening, junctional rhythm, and the gradually P wave gets faster, and then it starts conducting. So what was happening with this patient that there was marked sinus bradycardia, so there was junctional escape rhythm, and then when the sinus rate gets faster, the rhythm came back normal. All right, so next one.
Thank you.
We'll do this one. Anybody?
Sir, PR interval is, sir, I'm Mahmoud Hussain.
Okay, this is rate is 71 beats per minute, and you do the rest. Rhythm?
Rhythm seems regular.
And is it sinus or not?
It is sinus, but the PR interval is prolonged.
How long?
So,
How long is the PR?
yes, sir.
How long?
PR is about 360 milliseconds.
Yeah, 360 or close to 400 because two big boxes, 400 millisecond PR. QRS duration?
QRS duration is 40 milliseconds.
No, I think it's two boxes, 80 milliseconds.
80 milliseconds.
QT interval looks normal interval. It's about 400 milliseconds.
400.
So what is your diagnosis? Final conclusion.
So it is a case of first degree heart block.
Good. Sinus rhythm with first degree heart block. Please stay with me. I'm going to show you another ECG. How about this one? What do you think of this? Heart rate is 101 beats per minute.
Heart rate is 101 beats per minute. Rhythm is regular.
Yes.
But
where is it coming from? So
it comes from in lead V2. There is a POF.
Where?
Just after the TOF.
Yes. So this is I gave you this ECG because look at the same patient. So when the heart rate was 71, the PR is long. Heart rate becomes 78. You see the P wave is now coming close to the T wave.
Yeah.
And when the heart rate gets faster, you can see V2, you can say, but if this rate goes to another little bit higher, you won't be able to tell it. So when patients have first degree AV block, it is sometimes very difficult to see the P wave. So I give the follow-up ECG. So this can happen frequently. And at that point, let's say if this patient's heart rate was 130, 140 beats per minute, and the P wave is inside the T wave, you will not be able to distinguish it from supraventricular tachycardia. Thank you.
Thank you, sir.
I want somebody else.
Dr. Buddhadev Ganguly.
Heart rate is 78.
Namaskar, sir.
Namaskar.
Ji, sir. Sorry, it is normal sinus rhythm P wave present in wall of the lead. PR interval prolonged near to 400 milliseconds.
No, it's not 400. If you look at the grid, if you look at lead 2, you'll find that one big box, maybe two small boxes. So it's about 5 and 7 small ones. So it's about 280 milliseconds.
Yes.
Okay. QRS duration normal.
Yes.
Why did you say it's sinus rhythm?
Sir, sinus rhythm, sir, P wave present and same morphology and P wave upward in all the lead.
Upward in all lead is not a criteria, but it has to be upright in lead 2 AVF and lead 1. So those are the main criteria that defines a sinus rhythm. Okay. QT interval is difficult to see, but I'll tell you it's about 320 milliseconds. So what is your conclusion?
Sir, sinus rhythm with first degree heavy block.
Sinus rhythm with first degree. This is a clinical finding. I mean, you don't have to do anything about it because most of the time, first degree AV block, we don't do much about it. As you can see, the patient before had a much longer PR interval of 400 milliseconds, but that was a young person, had no problem at all. I want somebody to do this one.
Dr. Afsana or Dr. Mehnaz, anyone?
Sir, Assalamu alaikum.
Understand?
Thank you, sir, for giving me the panel.
Heart rate is 54 beats per minute. What's going on here?
Heart rate is 54. That means it is bradycardia, sinus bradycardia. P wave is present in normal morphology and upright in lead 2, 1 and AVF also.
Good. So
V1A it is sinus rhythm, sir, but there is in lead 2 there is a ectopic, I think so, sir.
Yes, so that's what I want to know. What's happening here? So you are looking at the rhythm strip, right?
Yes, sir.
Okay,
Rhythm
so
strip showing.
forget about the first QRS, right?
Yes,
second
sir.
QRS, and then there is another close by, right?
Yes, sir. There is a
and there is a longer interval.
Longer
What
interval.
is happening? Anybody else can help us?
Sir, progressive prolongation of PR intervals followed by offbeat.
Okay, who's speaking?
Mahmoud Hussain.
Okay, good. So, Afsan, I'll tell you something. So this P, no, it's not 2 to 1. I'm going to show you the next ECG. Look at this.
Followed by drop.
Okay, this P to the QRS 240.
Second degree mobile type 1, sir.
320.
Yes. 320, and this P wave did not conduct.
Yes, sir.
This one again back to short. Next one longer. Next one block. So there is progressive prolongation of Wenckebab IV block. So you can call it Wenckebab IV block or second degree type 1. Both terms are widely used. So Mobius type 1 or Wenckebab IV block. So remember this. Progressive prolongation of PR interval followed by drop beat. This one dropped after the second beat, and there can be other varieties.
Yes, sir.
So this is another one. Same phenomena going on here. If you look at lead V1, see PR, and then there is a little bit longer PR interval, and then this P did not conduct, and this is short, and then prolonged, dropped. So this is again Wenckebab. This one after one beat here, PR is short, longer, and then drop. And this is the feature of Wenckebab IV block. Another thing that will happen, if you look at the RR interval, it will gradually get shorter as Wenckebab progresses. So please remember, again, this can be a very benign arrhythmia. It is present in both young and older persons. Sometimes during sleep, you will see this Wenckebab IV block. Most of the time, you don't have to do anything about it.
Yes, sir.
So this is again, this is the second one I'm doing. If you look at the P wave, that PR is 240 millisecond, 310 millisecond drop, 240, 280, 320, and then drop. So gradual progression. And the RR interval gets shorter, 930, 910. Shortening of the RR interval before the drop beat. Thank you.
Thank you, sir.
Who will do this one?
নতুন কেউ? Anyone new? Dr. Mirza Muhammad Mursalin. Acha, who is this? Okay,
thank
Dr.
you.
Dr. Mirza Mursalin.
Thank you. Assalamu alaikum, sir. In this ECG, heart rate is about 40 or 39 beats per minute, and there is PR interval is variable PR interval, and RR interval is fixed. And so my final diagnosis could be complete heart block, sir.
Okay, so just explain that to me. Look at lead V1. Can you see my arrow?
Sir. Yes, sir. Yes, sir. Yes, sir.
P to R, right?
Yes, sir.
Next one, P to R, they're almost same, right?
Yes.
Next one is same.
Yes, sir.
Next one is same, right? So PR is not variable in this case.
Yes, sir.
And what is this one? What is this thing?
Okay, this is also a POF, and we cannot. I just missed it. It looks like POF, sir.
So there is no QRS
But
complex, right?
yes, sir.
So what is this? Conducted, P conducted, P no conduction, P conducted.
This is 2 to 1.
Yes, so this is 2 to 1 AV block.
Yes, PR interval is, yes, in this case, PR interval is fixed. If we say PR interval is fixed, so it could be a.
So it is 2 to 1 hard block. And that's
Yes,
all
sir.
you can say about this. QT is slightly prolonged because most likely due to the bradycardia. Whether it's Mobius type 1 or Mobius type 2, it is difficult to say, but this is actually the same patient that we saw before, the same patient. He was Wenkaba before, and later on he became 2 to 1. So it is probably type 1. I mean, it's Mobius type 1, second degree 2 to 1 hard block. Thank you.
Yes, sir. Thank you, sir.
Somebody else to do this one?
Okay, Dr. Shubhagata Saha, আপনার hand raise করা আছে. Let's see.
Sir,
46.
yes, sir. So it's sinus rhythm. QRS complex is 160 milliseconds.
Okay.
PR interval is
how much?
Sir.
What is the PR? Four boxes. Probably 4 boxes. So 160
Sir,
milliseconds.
Probably 160 milliseconds.
Okay. So what is your diagnosis?
So there's T inversion in V1.
Yes.
In V2.
Okay. So fine. Heart rate is 46, right? PR
Yes, sir.
is
Sinus
160.
bradycardia.
QRS duration is 160. Why is QRS wide?
Sir.
It can be right bundle, it can be left bundle, or non-specific interventricular conduction delay. What type is it?
Sir, Dr. Farhana Tina লিখেছেন right bundle branch block.
Good. So because there is an M pattern, you see small r, S, R pattern in lead V1.
V1 and W pattern in V6, sir. Right.
No, in V6, big R and deep wide S wave. Okay. And that is consistent right bundle. So you said sinus bradycardia with right bundle branch block, right?
Yes, sir.
And that is a common diagnosis, but anybody else have anything else to add to this?
Sir, I have to add something. Left axis deviation. Sir, I have to add, sir, left axis deviation is there. RBV left ventriculariscal block, and there is twist to 1 block. As alternate P is not conducted.
Yes. So look at this carefully. Every time you see a heart rate 40, 46 in the presence of bundle branch block, remember this. If you look, I'm going to show you lead 2. You can see my arrow, right? P QRS. But there is something here. And that may look like part of the T wave, but this is actually P wave. This has no QRS complex. Second one, third one conducted, fourth one did not. So it's 2 to 1 hard block, right bundle, and there is left axis deviation. So the diagnosis is 2 to 1 AV block, right bundle branch block, left anti-fascicular block. And this one probably, I mean, I will not confirm with it. I'll just say most likely Mobius type 2, because there is no PR prolongation. We cannot see if there is any Wenkaba behavior, but so thank you. Who did it second time? Who added that?
Dr. Mustalin.
Yeah, so that's good. Fantastic. Thank you. I'm going to do another. So look at these numbers. P to P, 660, 660. This one is a little short, 620. And this RR is exactly double of P to P. 660 plus 620 makes 1280. This is 1280. 660, 660. This is 1320. So look at the RR interval is double of P to P interval if we measure it. And the relationship is consistent. Thank you.
Okay, Dr. Farhana Tina or Dr. Jerin Shammi, any one of you two.
Okay, this one. Heart rate is 39 beats per minute.
Assalamu alaikum, sir.
আপনার পরিচয়?
I am Dr. Jerin Shammi.
ওকে, আপনি এটা ভালো মতো পারলে আপনার জন্য একটা বই।
Thank you.
Heart rate is 39 beats per minute.
Yes, from the ECG I can see there is P wave, but it's the rhythm is sinus. There's RR interval is fixed, but PP interval is fixed, but there is no relation with P with the QRS complex.
Okay.
And there is also the R wave is the QRS complex is wide.
Yes.
It's around
180 millisecond.
180 millisecond. Thank you, sir. And there is RSR pattern in P1. So it's right bundle branch block. So it's
and then what? Now one more thing. What is the QRS axis?
QRS axis is left axis deviation.
Left axis deviation. So what is your diagnosis?
So I think it's a trifascicular block.
What? You were almost right, because you said there is no relation between P and QRS complex.
Yes, there is a complete heart block also.
Perfect. Complete heart block with escape rhythm with right bundle left antifascicular block.
Yes, sir. Yes.
Okay. So stay with me. What I have done, I have put the P waves. Look at the P waves. So I have put the P waves here. You can see it here. And this is a P wave because you see this notch is absent here, and maybe this is the P wave. And there is a P wave here. There is another P wave, and probably there is another P wave inside the QRS complex here. We cannot see. Same here.
Yes.
The way if you suddenly look at this ECG, it looks like prolonged PR interval, right?
Yes.
But they're variable, and you can see here there is another P wave is coming out, and there is another P wave. These two P waves make the AV dissociation very evident. But if you look suddenly over here, it looks as if
like prolonged PR.
Yes, it looks like first degree AV block, but actually they are variable if you measure it. And if you come towards the end of the tracing, you can see the dissociation. So basically, this is complete heart block. Thank you. You did get great.
Thank you, sir.
So this same patient. Oh, can you stay with me?
Yes, I am.
Yes. So same patient. So this was done on the 9th of April 2004. I think for some reason nobody did anything. And then 13th of April. Can you tell me what's happening here?
I think there is some ectopic beats.
Okay.
Some sinus rhythm, and after that there is an ectopic beat, and after ectopic there is maybe ventricular white complex tachycardia, maybe ventricular tachycardia. And
yes, but what is this tachycardia called?
I think there is twisting of the axis, so it might be torsades.
Yeah, torsade. Perfect. You see, look at what happened is same patient still in complete heart block. You see the PR is changing.
Premature contraction sudden developed torsade point.
Yes. Okay, so the P wave, there is a pause, long QT, and then it develops torsade. And then, so we put a permanent pacemaker in. You can see that there is dual chamber pacing, atrial P wave followed by ventricular paced rhythm. So patient did fine after that. Thank you. I want somebody else to do this one.
Dr. Kamruzzaman.
Heart rate is 40.
Okay, Dr. Kamruzzaman, it's your turn. If not, then Dr. Farhana Tina. আমি চাই যে আরেকজন অলরেডি তিনজন সিলেক্ট আমরা মোটামুটি করছি, ডক্টর হানিফা আহমেদ, ডক্টর বুদ্ধদেব, ডক্টর জেরিন শাম্মী, তিনজন। ওকে, ডক্টর ফারহানা টিনা, প্লিজ।
Sir, assalamu alaikum, sir.
Yes, Sam. I've given heart rate is 40 beats per minute. You tell me the rest.
Sir, PP interval is regular. RR interval is regular. There is a left axis deviation.
Okay.
And sir, it seems to be complete heart block with left axis deviation, and there is ST depression in V5-6 and also T in V4.
Okay, good. So complete heart block. You see, if you look at this ECG, it looks like there is a PR relation, right? Prolonged PR, right?
Yes, sir.
But over here it changes.
Yes, sir.
And here you can see a second P wave.
Yes, sir.
So look at this. What I have done, I have put the P waves here. Look at here. So there is a P here. There is a P, and I think there is a P over here that is distorting the tube. This P, there is a P wave here. I put a question mark here. Another P, but there is clearly a P wave here.
Yes, sir.
Wave over here. So you have to carefully look at these rhythms. Even though if we suddenly look at this place, it looks like sinus bradycardia with first degree AV block. But as you keep following this, both of these ECG are similar ECG. There you can see the AV dissociation. Thank you. Great job.
Thank you, sir.
Congratulations, Dr. Farhana Tina.
Thank you.
Okay, I want somebody else to do this thing.
Okay, someone new.
স্যার আসসালামু আলাইকুম।
আপনার পরিচয়?
আমি ডাক্তার কামাল পারভেজ, আমি পেজে রেসিডেন্ট হিসেবে আছি।
Okay. Heart rate is 103.
This ECG show wide QRS complex in the M pattern in V5, V6, and also in one AVL. It is left bundle branch block.
Where is the M? Where do you say M in V5?
There is a notching in the QRS complex.
No, but
QRS complex.
Okay, lead V6. Does it look like an M?
No, it does not look like M.
So M pattern you will find in lead V1 in right bundle. There is a notching here, but does it look like an M? It doesn't.
Yes, sir.
This is a wide QRS complex in V6. Positive. And this is a negative. So, and what is it? What kind of rhythm is this?
This is P morphology is positive in 2 and 1 and AVF.
So
this is
sinus tachycardia. Sinus tachycardia, right?
Sinus tachycardia. Yes, sir.
And why the QRS duration is about 160 milliseconds. So why is the what kind of bundle is this? Right
Okay,
or left?
Dr. Hanif, do you want to add something?
Hello. Hello.
Yeah, Hanif, please. Do you want to add something?
No.
Sinus tachycardia. My question is, why is the QRS wide?
Hello. Assalamu alaikum, sir. Sir, there is the heart rate is, sir, about 100 beats per minute, and there is P wave, sir, in front in upright P wave in lead 2, and there is short PR interval, sir.
Well, it's not very short. It's about 130 milliseconds. So that's not very short.
Oh, jeez.
QRS duration is 160 milliseconds. Why is QRS wide?
Sir, the QRS seems, sir, slurred a bit, sir. in lead
Yes.
2.
That is very true. That's what I'm asking.
Sir,
QRS is
maybe it's a
wide.
WPW syndrome.
Okay. Why are you thinking? You are thinking a little more complex. If it is true, it can be WPW syndrome, but in WPW syndrome, the PR should be shorter.
Yes, sir. Sir,
Anybody?
Okay,
You were about to say something.
Dr. Rahmatullah
There
from
could be a
Rangamati.
flutter, sir, underlying bundle block.
Okay. Anybody else?
Sir, sinus tachycardia and
Sinus tachycardia with LBB morphology.
Okay,
LBB
who said
morphology.
left? Good. Who said left bundle branch block?
Sir, left bundle branch block অনেকেই বলছে স্যার, আমি বলি ডাক্তার রহমতুল্লাহ ফ্রম রাঙ্গামাটি বলছে লেফট বান্ডেল ব্রাঞ্চ ব্লক, ডাক্তার সাব্বির বলছে সাইনাস ট্যাকিকার্ডিয়া লেফট বান্ডেল ব্রাঞ্চ ব্লক। তারপরে স্যার ডাক্তার বুধ, হ্যাঁ।
Okay, so just remember, I'll show you another ECG. First of all, sinus tachycardia. The QRS complex in lead V6 is positive, wide QRS, and a negative S wave in lead V1. Sometimes you will see R wave like here. And that's very much typical of left bundle. And in lead 1, you will see a positive R wave. This is a little small left R wave. So I'm going to show another ECG to contrast. This one is the M pattern that we were talking about. If you look at, this is sinus rhythm 84, PR interval is about 160, QRS is about 140. There is a RSR pattern, which is like an M here in lead 1, V1, and wide R and deep S wave in lead V5, V6. That's right bundle. So the difference, look at the difference between the two. V1, V6, positive in V6, negative in V1 left bundle. In right bundle, there is an M pattern in V1 and then deep S wave in V6 and V5. That's right bundle branch block. So please remember these two morphology, and then anything that does not fit into this description becomes a non-specific interventricular conduction delay. I want one person to do this. Next one.
Okay, Dr. Afsana. Dr. Afsana, you own a book already, but you didn't contact with me or didn't given me your address. Okay, Dr. Afsana, please.
স্যার এখানে আছে সাইনাস ট্যাকিকার্ডিয়া আছে সাথে রেট 68।
Yes.
না সাইনাস ট্যাকিকার্ডিয়া এটা লেফট বান্ডল ব্রাঞ্চ ব্লক বলবো স্যার। Sinus rhythm with left bundle branch block.
Okay, tell me why do you say left bundle branch block?
And there is it is white QRS complex and one enable showing RR pattern.
No, make it simple. Lead V6, a big positive R wave.
6 M pattern.
No,
small R.
There is no M pattern. Ignore, I don't know why you are getting this M pattern in V6. In V6, there is a positive R wave. In lead V1, small R, deep S wave. That's left bundle. And sometimes, and also always, you will see a positive R wave in lead
1
lead
and
one.
AVL.
1 AVL. That's it. Forget about the M. M will be in lead right bundle. Okay. Afsana, you stay with me. You do this one. Next one. This is the M we are talking about. Tell me about this one. Heart rate is 63 beats per minute. PR interval is 224. Tell me what it is.
Sir, RSR M patterns are in V1 and
Yes.
V2.
Yes.
And
No, V2 is not M.
V2 is not M, sir. V1.
V1, that's enough. V1
Yes,
RSR pattern in V1 is good enough. And then in V6, there is a deep S
V6
wave.
there is deep S wave.
So what is
and
it?
T inversion. So it's a right bundle branch block.
Okay, and what is the QRS axis?
It's a trifascicular block.
Right bundle branch block.
No, QRS axis. What is the QRS axis?
Axis, sir. Here in
Is it left axis, right axis deviation?
No,
What is it?
One AVF, sorry, sir. It sir, the left axis deviation. It seems to
Exactly.
be bifascicular block, left anterior, right bundle branch block with left anterior hemiblock.
Yes, perfect. So right bundle, left anterior fascicular block, and then also it has first degree AV block. So sometimes we use the term trifascicular block. So basically first degree AV block, right bundle branch block, left anterior fascicular block. Clinically, it doesn't mean anything. If somebody has this ECG, and they have no history of syncope or pre-syncope, we'll do nothing. But if this ECG patient has syncope, then most of the time people will implant a pacemaker because most likely etiology of syncope is intermittent complete heart block.
স্যার একটা কোশ্চেন ছিল স্যার।
Yes, go ahead.
স্যার V2 and V3 তে কি স্যার ইপসিলন ওয়েভের স্যার কোনো চান্স আছে স্যার? V2 and V3 স্যার যে V2 তে স্যার এটা
There is a complex funny wave, but with bundle branch block you cannot diagnose epsilon wave. That will apply if you have normal QRS duration.
Thank you.
This is fragmented. So one of the thing is that at your level, think simple. What I mean by that, if you do not recognize epsilon wave, nothing will happen to your patients. But if you don't recognize right bundle branch block and left anterior fascicular block, you will miss something important. So in ECG, we always give some importance to what is crucial and what is not crucial. Academically, yes, there is a funny wave there. You can see this sharp spike, but that's part of the conduction system abnormality. This is not epsilon wave. Thank you, but thanks for pointing out. Okay, so I'm going to do few more ECGs that we have not done before. So somebody wants to do this one, and I will help.
That there is pacemaker spikes before each period.
Single.
Okay. No, let him finish it.
Pacemaker.
একজনকে শেষ করতে দেন প্লিজ, লেট হিম ফিনিশ। ওকে,
continue.
So heart rate is about 60 beats per minute.
60 beats.
There is pacemaker spikes in front of each POFs. So my diagnosis is atrial pacing.
Okay, good, perfect. So atrial pace rhythm. Is it a single chamber pacemaker or dual chamber pacemaker?
Single chamber pacemaker.
Yes. So even if this patient has a dual chamber pacemaker, there is no ventricular pacing. So I cannot tell whether it's single or dual chamber, but by pacing, it is a single chamber pacemaker. It's pacing in the atrium with PR interval 200 milliseconds. Then rest of you also have to, when you interpret this ECG, because it is a conducted QRS, you can also assess the QRS duration, QT interval, all those things. Please stay with me. I want you to do this ECG also. What do you think of this one?
Heart rate is 82 beats per. Heart rate is 82 beats per minute.
Yes.
There is POF. PR interval seems normal. And
218 beats per millisecond. It's a little prolonged. Okay.
There is an ventricular ectopics.
Okay. Ventricular premature beat.
Ventricular premature beats.
Yes.
And
so what is your diagnosis?
So ventricular premature beats.
No, give me the full diagnosis. Sinus rhythm or not sinus rhythm?
Sinus rhythm, sir.
Okay. So remember one thing. Look at this. You saw that big spike, right? Pacing spike. Sometimes it is difficult to see pacing spike. So what I have done, I have taken the V1 and I have expanded it. See the spike? Look at this tiny pacing spike.
Yes, sir.
So this is actually a atrial paced rhythm. But if you could not tell it, I will not blame you for that. But keep an eye on it. Look also lead V1 here. Is it the spike now?
Yes, sir.
Very tiny spike. It is mainly because what happens, these are bipolar pacemakers, and also how it is filtered by the ECG machine. That decides whether you can see the spike or not. Again, same. This is basically an atrial paced rhythm. It's a different patient, I think. Yeah, different patient. So you could not see the pacing spike unless we magnified it. So atrial paced rhythm. Thank you. Anybody else?
Dr. Rahmatullah from Rangamati.
Heart rate is 69 beats per minute.
Assalamu alaikum, sir.
Namaste. Heart rate 69, you do the rest.
And sir, P is biphasic in 2-3 ABF.
Okay.
And PR interval seems to 200 milliseconds.
Yeah, okay, fine. I measured 190, but 200, I'll take 200 is fine.
And QRS complex is about 80 millisecond.
Okay.
And QT interval is about 360 millisecond.
360 millisecond, perfect.
And ST segment is almost
normal.
Isoelectric.
Isoelectric. Look in lead V1. Do you see anything?
V1 is a T inversion, sir.
Or anything else? Okay. So fine. So what is your diagnosis? Sinus rhythm or non-sinus rhythm or anything else?
So, heart rate is 69 beat per minute, and sinus rhythm, and there is a before P wave in V1. There is spikes.
Yes. Okay. Look at this. I magnified it again. See this P wave? There's a sharp something. Look at here. When I magnified it, you can see it better, right? So this is an actual
pacing.
Actual pacing. So when you see something, it can also be an artifact. But look at other leads. If it is there everywhere, every QRS complex has this P before P wave, and you can see this. This is actually an actual paced rhythm. So if I go back here, you cannot see in any other lead except in lead V1 and maybe V2. It's very difficult to see. But this is very common with new pacemakers. Old pacemakers, you could see the big spike, either they were unipolar or by the filtration, how the signal is filtered by the ECG machine. New ECG machine, sometimes you don't see this unless you really carefully look at the spike. Okay, thank you. So actual pace rhythm. So this is another one. Again, you can see the actual pacing spike, but look at the QRS. QRS looks kind of funny, and I was wondering if there is another pacing spike. So it is possible that atrial paced, there is a AV delay program. By that time, there is normal QRS complex, and it paces the ventricle without capturing it. So it's called pseudoffusion. And then same patient, at a different time, you can see the ventricular pacing. Patient goes into atrial fibrillation. It's just ventricular pacing, underlying atrial fibrillation. I think we are almost 1 hour, right, Hassan?
Yes, sir.
So shall we stop it here?
Your wish, sir.
Okay.
Convenience, sir.
Depending on the audience, what do they want? Anybody wants to do this one?
Okay, Dr. Nobin Shah or Salman Rafat, anyone? Dr. Salman, Dr. Nobin, Dr. Saidur. তিনজনকে অপশন দিলাম, এনিওয়ান। এটা কঠিন লাগতেছে?
I will help.
স্যার একজন আনসার দিয়ে দিয়েছেন ডুয়েল চেম্বার পেসমেকার।
Okay, who answered? I want to talk to him.
Okay, Dr. Buddhadev, please.
Namaskar, sir.
Namaskar. So heart rate is 68. What do you think is this?
Sir, heart rate, sir, sir, sinus rhythm, sir, QRS white, LBB morphology, sir, and sir, dual chamber pacemaker.
Why do you say dual chamber pacemaker?
Sir, dual chamber pacemaker, sir. স্যার এখানে স্যার ভেন্ট্রিকুলার পেসিং এন্ড স্যার এটা স্পাইক মনে হচ্ছে স্যার, মানে পরপর দুইটা স্পাইক স্যার, এই জন্য একটু কনফিউজ।
ওকে, নো, ওকে, ফাইন। সো দ্যাট ইজ pacing spike. You can see my pointer.
Yes, sir.
Okay, pacing spike, right?
Yes, sir.
And the QRS. There is a pacing spike QRS, right?
Yes, sir.
So this pacing spike, which chamber? This spike?
Sir, ventricular, sir.
Ventricle. So, and then why did you say dual chamber? You are right, but why did you say dual chamber? Because there is no actual pacing spike.
Yes, sir.
No, but you are correct. Okay, so what's happening?
দুজনের আনসার ছিল স্যার ভেন্ট্রিকুলার পেসিং।
Okay, ventricular pacing is correct, but Buddhadev is correct answer. Dual chamber pair, because look at the P wave and the QRS, there is a constant relationship. So that they must be linked somehow. So what is happening? There is a electrode in the atrium. It senses the P wave and sends the signal to the pacemaker. And the pacemaker says, let's see if there is a QRS. If there is no QRS, then it paces the ventricle. So atrial sensing, ventricular pacing. Atrial sensing, ventricular pacing. Atrial sensing, ventricular pacing. If it were just single chamber ventricular pacemaker, there will be no relation between this P and the pacing spike. But this relation is constant. So Buddhadev, you are correct answer, but just remember this thing, okay?
Thank you, sir.
Okay, now, Buddhadev, stay with me. How about this one? This is again, no, I'm going to go back. This one again, it's a little difficult. You see, difficult to see the pacing spike, so it's the AV sequential pacing. But look at this one. Here, you can see both pacing spike. If you look at here, it is pacing the atrium, causing P wave, and it is pacing the ventricle, very small spike QRS. So this one will diagnose as at AV sequential paced rhythm. The one before, the one that Buddhadev said dual chamber, I will call it atrial sensed ventricular paced rhythm. That will be a good way of describing it. So over next time, we'll do more of this kind of ECGs. Let me see if there's anything else interesting. So this is a better ECG. You can see there is atrial pacing spike producing a P wave. You can see the ventricular pacing spike producing a QRS complex. So this is clearly dual chamber pacemaker. This is a little tricky. No, I don't want to do this. All right, thank you. I think we'll stop here. We'll do again next time. So shall we do a random ECG next time also? What do the audience wants?
স্যার এটা আমি এখন আপনার সেশন শেষ হলে অডিয়েন্সের সাথে কথা বলবো। আমাদের তো নেক্সট দুইটা সেশনের আমি টপিক স্যার আমরা ঠিক করে ফেলবো। আমরা নেক্সট আর যে দুইটা সেশন আমরা স্যার টপিক ঠিক করে আপনাকে স্যার আমি অডিয়েন্সের সাথে বসে এখন আমি ফাইনাল করবো স্যার। দেন আপনাকে স্যার আমি পাঠিয়ে দিব। আমাদের আর দুইটা সেশন আমরা কন্টিনিউ করব। স্যার এখন একটু কনক্লুশন করার জন্য স্যার মাহমুদ হাসান স্যারকে আমি একটা আহ্বান জানাচ্ছি স্যার।
জি, থ্যাংক ইউ অনেক ধন্যবাদ ডক্টর এহসানুজ্জামান সাহেব এবং বিডি ফিজিশিয়ানসকে ধন্যবাদ, এবং ধন্যবাদ জানাচ্ছি যারা পার্টিসিপেট করলেন, তারা অ্যাক্টিভলি পার্টিসিপেট করেছেন, এবং ডক্টর রফিক আহমদ সাহেব অত্যন্ত সুন্দরভাবে উইথ গুড এক্সাম্পলস উনি আমাদেরকে দেখিয়েছেন। এবং আমি বিশ্বাস করি যে এই যে কয়টা ক্লাস হলো 6টা প্লাস, এতে ইসিজি সম্পর্কে আরো ক্লিয়ার আইডিয়া সবার হচ্ছে, এবং কার্ডিওলজি ভালোভাবে শিখছেন। এজন্য রফিক আহমদ সাহেবকে অত্যন্ত কৃতজ্ঞতা এবং ধন্যবাদ জানাচ্ছি। উনি বাংলাদেশের জন্য অনেক কিছু করেছেন, আর আগেও আপনারা জানেন, আলোচনা করেছি আমরা, এবং এটাও ওনার একটা বিরাট কন্ট্রিবিউশন। তো আমি রফিক আহমদ সাহেবকে ধন্যবাদ ও কৃতজ্ঞতা জানাচ্ছি, পিডি ফিজিক্সকে ধন্যবাদ জানাই, এবং যারা হোস্ট করলো আজকে, এসিআই না হেলথ কেয়ার
স্যার,
হেলথ কেয়ার ফার্মাসিউটিক্যালকে আমি কৃতজ্ঞতা জানাই, ধন্যবাদ। জি, আপনারা ভালো থাকুন, সুস্থ থাকুন, আসসালামু আলাইকুম।
ধন্যবাদ।